Welcome. This training is brought to you by the New Hampshire Training Institute on Addictive Disorders. You can access the recording of this webinar on our website at nhadaca.org within our webinar library. After completing this training, please complete the quiz and evaluation if you're interested in receiving a certificate. You can find the quiz and evaluation on our website next to the Watch Now button you selected to view this webinar on our website. If you're a member of NHADACA or NADAC, the certificate for this webinar is free. If you are not, the fee is $15. You will receive a certificate worth 1 CE once you have completed and passed the quiz and paid for the webinar, if applicable. Through the New Hampshire Training Institute on Addictive Disorders, this 1-hour event is pre-approved by the New Hampshire Board of Licensing for Alcohol and Drug Use Professionals, as well as NBCC. If you have any trouble viewing the webinar, audio problems, or any other technical questions, please contact us at 603-225-7060. Please email any questions regarding the material you see today to training@nhadaca.org. Thank you, and now the training.
My name's Al Hassan. I recently retired from the University of California, Los Angeles, and have been working in Northern California with the Pinoleville Pomo Nation, a native tribe in Northern California, opening up an opioid treatment program. I've worked as a researcher evaluating medications and behavioral interventions for the treatment of substance use disorders. I was part of the developer of the Matrix model, and have been training for the last 5 or 6 years with the Pacific Southwest Addiction Technology Training Center at UCLA. So it's a pleasure to join you today. And what we're going to talk about, obviously, is stimulant use disorder, but I'm going to present a little bit about the TRUST model, the TRUST program that Dr. Rawson, Rick Rawson, at the Center for Rural Addiction at the University of Vermont, and he also continues to work at UCLA, have developed over the last year. So again, it's a pleasure to be here with you today. In terms of what we're looking at, we're all familiar with what's happening, in terms of overdoses, and this is really the fourth wave of the opioid overdose, what we're seeing right now. This data is from 2019, about 70,000 deaths, overdose deaths related to substances. What's fascinating, though, is that the data is coming out all the time now, and in the period, I believe it was ending August of 2020, so the 1-year period ending August 2020, there were over 88,000 deaths from substances. So we're seeing the impact that COVID has had on overdose deaths, and certainly I don't think this is news to any of us that people would be more impacted as they isolate themselves more and more. We know that when individuals who have mental health disorder isolate themselves, bad things happen. When people who have substance use disorders isolate, bad things happen. And so we're seeing increases in overdose related deaths. The red line is synthetic opioids other than methadone, and it's primarily what we're seeing in fentanyl, and what we're seeing across the country is that fentanyl is part of the stimulants, both cocaine as well as methamphetamine. The blue line is our stimulant overdoses, and that's at 30,000, and you can see it's pacing with the synthetic opioids. And then the other is natural and semi-synthetic opioids, and that's tailing off a little bit. It also includes methadone and then heroin. And what we saw, in 2010 is when they came out with the abuse deterrent Oxy, people switched from that to from oxy to heroin, and now we're seeing much more fentanyl in the mix these days, both in stimulants as well as in what is presented as opioids. The challenges that we have with individuals who present for stimulant use disorder, obviously overdose death, and a lot of it is related to fentanyl being included in the drug. Many people don't realize that they're actually taking fentanyl. Limited understanding of stimulant addiction. A lot of the patients don't, people who present with stimulant use disorder don't, they don't really understand, what they're going through. It doesn't have the same sort of preset withdrawal patterns that you might see with alcohol or with opioid use. And along with that, people can stop periodically, right? And so they think that they have, control over it. And so there's some ambivalence about the need to stop. There's obviously poor judgment and impulsivity that goes along with that, and the cognitive impairment, and especially with the purity and with the purity that we're seeing these days, it's much higher. And the cost is much lower than it has ever been. Along with that, anhedonia, the inability to experience pleasure. And if you're not getting pleasure from the things that you've normally found pleasure, spending time with your family, spending time with your children, engaging in recreational activities, the enjoyment from either work or educational pursuits, basically, the drug in and of itself is what people look forward to. It's the thing that's helping them get out of bed, every day. There's the hypersexuality, certainly while somebody is using, and then the hyposexuality, while somebody is going through withdrawals, and sort of the sense that they're never actually going to be able to function or perform sexually unless they have the drug on board. Violence and psychosis, we see that in the news all the time. And that powerful Pavlovian trigger craving response, it is incredible how many times I've heard people say, I didn't really intend on using. I drove by this freeway exit, I noticed that somebody was tweaking, or I noticed there was a certain smell. And the next thing I know, 3 days later, I've been using for 3 days. Obviously, there's very poor retention in outpatient treatment. And in some ways, it's where we always used to treat stimulant use disorder primarily on an outpatient basis, it really seems like we need to combine it with residential care to get people stabilized and then transition them into an intensive outpatient or an outpatient basis. The fact is, though, is we do a really poor job of transitioning patients from one level of care to another level of care. So some of the treatment considerations that we need to look at in relation to certain groups are individuals who inject drugs. We're seeing more and more of that, especially with stimulants. The challenges with HIV, Hep C is on the rise these days. People who are used on a daily basis. And then there's, women who are using, there's high rates of physical and sexual abuse. The homeless, so many patients that we see that are homeless, say that, look, I use at nighttime so I can stay awake, so I don't get mugged. I can protect my, myself and any of the, the people around me, but additionally, any of the belongings that I have. So they use it at nighttime, and they catnap during the day. And there's high level of psychiatric symptoms that go along with that. MSM, and then individuals in medication for treatment for opioid use disorder. We're seeing more and more individuals either who are being treated with buprenorphine or who are being treated with methadone are using stimulants, and they don't necessarily see that as being problematic. And so in terms of that, McMahan at Washington State University, they looked at sort of the interest in reducing methamphetamine versus opioid use at a syringe service program. They had a sample of just under 600 individuals, the majority of which about 3/4 of them were using opioids, about a quarter using methamphetamine. And what they found is that the majority, over 80% of the individuals who were using opioids as their main substance wanted to stop using. They expressed an interest in either reducing or stopping their use, while only 46%, under half of those individuals who are using methamphetamine, expressed an interest or desire in cutting back or stopping. And that, I think, really highlights the nature of the substance, but also that ambivalence that people are experiencing, as they continue to use, as it relates to treatment. When we look at dropout rates, Lappin did a systematic review and a meta-analysis that came out in addiction in 2020. And what they came up with was the dropout rates in psychosocial substance use treatment. And they did a meta-analysis. They looked at 151 studies with just under 27,000 participants. And they came up with the dropout rates and predictors of dropout as it relates to the substance that the individuals presented at treatment for. And, so the dropout rate, certainly for individuals who are opioid dependent, specifically heroin dependent, was about 25%. And, if they're not using medications for opioid use disorder, it's certainly much higher than that. Tobacco, about 25%, alcohol right in the same way. But then when you look at stimulants, you look at, cocaine at just under 50%, that's that retention rate. And those are some of the challenges that we have with individuals is keeping them in treatment. The name of the game here is retention. And, sometimes, when we take an abstinence only approach, we're going to lose people who otherwise might stick around if we have an approach that accepts that, sometimes people are going to use, and cutting back on use is a way to get individuals to recognize that they can control their use a little bit more, and also as a way to move them towards ultimately abstinence. So medications, we've done a great job with opioid use disorder. We've done a great job with alcohol use disorder in terms of identifying medications that are effective. We have a number of formulations for buprenorphine. We have methadone. We have a number of naltrexone formulations, including extended release naltrexone that are FDA approved. There's a number of medications for alcohol, including extended release naltrexone and abuse. But we haven't done such a great job with medications for stimulant use. Mirtazapine, which is an antidepressant, really has shown some effect. One of the challenges, though, with any trial that's looking at medications for any sort of chronic disorder is medication compliance. And that brings me to the buprenorphine and extended release naltrexone. Madhukar Trivedi and his colleagues at within the clinical trials, NIDA Clinical Trials Network, and they're at the University of Texas, basically tried a combination using extended release naltrexone and bupropion, or Wellbutrin, which is an antidepressant as well. The early pilot studies showed some great promise, but it was a non-blinded open label trial. About 30% of the people did well, and that's, that goes along. It was a very powerful intervention that included giving folks a cell phone and using contingency management as a way to get them to take their medication. In this trial, it's called ADAPT-2, ADAPT-2, And I recommend that you go on to the CTN, Clinical Trials Network, dissemination website, and you can look up that trial, ADAPT-2. But about 13% of the individuals actually did well over the 4 weeks. And that's about as good as we have in terms of medications. We've seen bupropion alone, naltrexone alone, methylphenidate, and other stimulants that for the treatment of stimulant use disorder. Some have an impact, but nothing that would reach the level of approval through the FDA. So let's take a look at some systematic reviews. Fouad, any questions that we have at this point?
There is one. Let's see. It says, can you speak? This is Cassandra asks you, can you speak to the new MAT medications being developed presently for meth use?
I guess I just did. So yeah, I mean, we've seen. Yeah, I think that, well, certainly the work is continuing. Mirtazapine and the combination of Wellbutrin and extended release naltrexone right now are at the forefront. I certainly don't see those as, we're certainly not going to stop there. The National Institute on Drug Abuse is spending a lot of time, energy, and resources to come up with a medication that's going to be effective, and to help us as clinicians to be able to help our patients, and so that we can be more effective at what we really at what we'd like to do. So right now, what we're looking at is the behavioral interventions. The behavioral interventions are the best thing that we have, and these systematic reviews and meta-analysis that we'll be talking about really go into that. So comparative efficacy trial. DiCrescenzo took a look at psychosocial interventions for both cocaine and amphetamine use disorder. It was a meta-analysis, so they looked at 50 clinical studies, just under 7,000 patients. They looked at 12 different psychosocial interventions, and what they came up with is that what they came up with is the combination of contingency management and community reinforcement approach. That combination was the most efficacious and most acceptable in terms of short and long-term treatment. Okay. In terms of the Lancet article, they looked at psychosocial interventions other than CM and well, in addition to CM, and they say basically that they have weak and non-specific effects on stimulant problems, and that we know that there's no effective pharmacotherapies, right? So research is continuing to develop on both pharmacotherapies as well as behavioral interventions. Ashrani here in the US, there are 44 studies that they reviewed, and basically said contingency management interventions showed the strongest evidence favoring outcomes assessed, and tailored CBT alone or with CM was also effective, but not, but certainly CM is the most effective. And so what we're going to spend some time talking about here today is the value of contingency management, and you might also know them as motivational incentives. CM is a technique where you employ the systematic delivery of positive reinforcement for specific targeted behaviors. So, in the treatment of methamphetamine use disorder, you can use vouchers or prizes, and patients can earn these for instance, for attendance or for methamphetamine free urine samples. So it really is the contingency that matters, and so when we've recognized that there's a behavior that we want to change, a targeted behavior, when that behavior occurs, it's best to provide the reward immediately following the target behavior. Now we see this in in all sorts, all walks of life. I mean, you're here right now because of a contingency. You're here for a couple of reasons. One is because you want to get CEs and maybe your CEs are due. Second of all, you're getting paid to do this. And so that too is a contingency. But we use contingencies in child rearing with praise and money or food. We use our for our pets. We give them a treat when they engage in the desired behavior that we're trying to teach them. In terms of education, grades and honors, and that are bestowed upon people are very powerful. In work, there's bonuses, when people meet certain criteria. And especially we see that in sales, when people have a certain limit that they need to reach in sales, and they over exceed or they exceed, they might get an additional bonus. And certainly within the criminal justice system, early release for good behavior. What we know about rewards is that they teach new behaviors. They help promote growth. They promote self-esteem and self-confidence. And we know with the population that we have, you may be the only source of positive sort of reward in their life. Their family's probably given up on them. The system is probably given up on them. The criminal justice system is coming around more and more to provide treatment as opposed to punishment. But that too is slow in coming. But promoting self-esteem, promoting self-efficacy, promoting self-confidence is really at the key to working with these individuals and having a positive atmosphere. That when they come in, they feel like they're a valued member of society. So incentives. So basically, you could use incentives for treatment attendance, though there are some issues, around that. Paying a bounty, and in California, what we experienced was a lot of Medicare and Medi-Cal fraud by paying bounties for patients to come in and then billing for those individuals without actually providing the service. So there's issues around actually paying for attendance, but as opposed to giving negative urine samples or rewarding somebody for a negative stimulant urine sample, giving them an incentive. Certainly you don't want the incentive to be cash. That's a major trigger for individuals. It usually increases treatment retention and has the potential to reduce stimulant use as well. So the behavior principles here, what we're looking at is you want to identify a target behavior and don't make it a secret. We want to ensure that people understand what that target behavior is so that they can modify that behavior in order to be able to receive the incentive or the reward. We provide the incentive when the target behavior occurs. So if we're providing an incentive for urine drug screens, it's going to be important, or negative urine drug screens, it's going to be important to use point of care testing, because providing a test, if a patient provides a sample and we send it out to the lab, and then 2 weeks later we give them the incentive, they may actually forget why the incentive was received. It might be because they may think it's because they combed their hair, or they took a shower, or it was because the color of the shirt they're wearing. So it's important to provide the incentive immediately, or as soon after as we identify that target behavior. And if the target behavior does not occur, we do not provide the incentive. I mean, purely and simply. But rather, what we would do is provide encouragement, provide praise, and let people know that we're still behind them, and try to figure out sort of what we could do differently to help the individual either reduce or eliminate their substance use. Any questions so far, Fuad or Alyssa, at this point?
Yes, there is one.
Okay.
Courtney wants to know, how do outcomes compare depending on the target behavior being monitored during CM attendance versus negative UAs for meth, for example. One is abstinence-based and the other is treatment retention, but use may still occur.
Okay, so let me see if I understand that. So if
I'll read it again.
Okay.
How do outcomes compare depending on the target behavior being monitored during CM? And then she puts in parentheses, attendance versus negative UAs for meth. One is abstinence-based, the other is treatment retention, but use may still occur.
Great. It's a great question. I mean, a really, really good question. So in other words, you know, if an individual gets rewarded every time they come in, it's going to increase the likelihood that they come in. No doubt about that. If a person cannot get abstinent, and that's really what, and that's one of the target behaviors. If they have challenges in getting abstinence and there's no other recognition for any other behavior, the likelihood is that they're going to drop out. I mean, and so it's going to be important to ensure that the incentive is large enough. And so having a large enough incentive for a negative drug screen could certainly push the person over the top on that. And what we do know is that the larger incentive, the greater likelihood that somebody's going to engage in the behavior. I hope that answers your question. Nancy Petrie developed a fishbowl, a variable magnitude sort of reinforcement procedure. And what they did was when they put 500 chips, like poker chips, and the chips can be exchanged for prizes, or they actually have a monetary value of which you can give a gift card. Half of the 250 are labeled good job. So there's no monetary value at all. And really what they were trying to do was to implement a low cost contingency management process into their program. So about just under 42% of the chips were a small prize, $1 to $5, might have been, a toothbrush or, some sort of hygiene thing. It might have been a gift, a gift card to, to a restaurant or something, some fast food restaurant or something of that nature, like Target or Walmart, in the areas. Sometimes they were grocery stores. And then a smaller percentage, just under 10, were a large prize at $20. And then, basically one of them was a jumbo prize, anywhere from $80 to $100. Now, a lot of programs don't have that kind of money. And so you could actually make the prizes smaller. And that's really, what she wanted to be able to do was to allow folks to implement contingency management program and be able to reduce the cost of that, because this was done in the clinical trials network. There was a lot of pushback from the community treatment providers because their sense was some of these things aren't sustainable once the research goes away. So we have to be able to sustain the project moving forward. And we can talk a little bit later about getting donations from the community, because that's been done effectively. John Roll reported data on 113 participants diagnosed with methamphetamine abuse or dependence. They were randomly assigned to receive 12 weeks of either treatment as usual or usual plus contingency management. And the treatment as usual, this too was done in the clinical trials network. It was one of the earlier trials. Basically, the results, both groups remained in treatment for equivalent times. So there's your, the retention issue. Those receiving contingency management, in addition to the treatment as usual, right, submitted significantly more negative samples, and they were abstinent for a longer period of time, 5 versus 3 weeks, than the treatment as usual. So they didn't alter the treatment as usual in the treatment program. It was whatever they normally do, we're just going to add the contingency management to it. And so you could see with the incentive, and this again is percentage negative urine samples, a much greater percent of negative urine samples were provided by those individuals who are assigned to, randomly assigned for that matter, to the incentive group. And additionally, so contingency management for the treatment of methamphetamine dependence, this is John Roll again. And what you can see is that the percent abstinent throughout the intervention. So TAU plus CM got a significantly stronger sort of response to treatment, when CM was added to treatment as usual. Closer to home here at UCLA, Rawson and Associates did a CM project with individuals at a methadone maintenance program. And so this was at the program that I was running at the time in South Los Angeles. We had a number of individuals who were using cocaine. They're on methadone. They were doing well on methadone, but they were using cocaine, and many of them actually did want to stop. It was a randomized trial. Patients with cocaine dependence receiving, so it was a total of 120. And we had a number of interventions. We had contingency management, we had CBT, we had combined contingency management and CBT, or treatment as usual. It was a 16-week trial, 3 clinic visits per week. So many of the patients, because they were continuing to use other substances, had to attend the clinic 7 days a week. But for this intervention, they had to come in. They had to show, they had to either go to group or see the research associate 3 times a week. So the results, the 2 groups with CM had significantly greater retention and significantly more negative UAs than the groups without CM. So those individuals in CBT were not significantly different. Their results, the outcome, wasn't different than those that just received methadone maintenance only. And so really the combination of CBT and CM was helpful, but the CM sort of really outshined even the combination of CM and CBT. So stimulant-free UAs, you can see the dark box there. About 20% had for CBT had stimulant-free UAs. The CM 30%. CBT and CM, it got a pretty good effect at 26%. And if they just got the methadone only about 11%. So the reality is addressing and talking to the patients about their stimulant use is, it does show some help, but most importantly, if we want to get a better bang for our buck, utilizing CM would be really helpful. The Veterans Administration, Nancy Petrie and Dominic DeFilippis, they actually instituted a nationwide dissemination of CM, and it's still ongoing, and they're finding that that's incredibly effective. Dynamic Care is a phone-based app that's a platform for families and individuals as a way, and programs for that matter, to reinforce recovery-related behaviors, either using random breath or saliva tests, treatment attendance. It has a supportive recovery coach, and there's monetary rewards. They're using this in West Virginia at this point. 3 major challenges, though. This is really where the difficulty comes in terms of implementing a contingency management. First and foremost, it's staff resistant to the idea of actually paying people to do what is right. They're being bribed. Why should we pay them to do, to engage in recovery? Motivation needs to be intrinsic. It shouldn't be external. But the reality we know is that compulsory treatment works. I mean, we see that. And also what we know is that we can enhance motivation. And if you've taken any motivational interviewing courses, which I'm sure you probably have, you recognize and have been taught that Resistance really is more of a challenge for the therapist. It's less of a challenge with, with the patients. The patients don't even recognize that's what they're going through. And when we talk about resistance, that's we're using actually a stigmatizing term by saying, well, you're in denial. You're not ready to make those changes. The reality is if they're in our office, they're ready to make some changes. If they've made that phone call, they're ready to make that change. And even if it's a court mandated, because they have a choice, they can either go to jail or, get into treatment. The other issue is, where does the funding for incentives come from? And right now, this is changing. Medicaid regulations that restrict incentives that we can give it to patients is $75 per patient per year. That is changing, and so there are some programs. In fact, in Montana, Montana is one of the first programs that's looking at higher rewards at $300. But the issue regarding that is maintaining strict security, maintaining documents as to how the incentives are being provided. CM for the treatment of methamphetamine use, Brown and DeFolio, a review of 27 studies included contingency management for individuals with stimulant use disorder. The outcomes improved drug abstinence. They retained people in treatment longer. Attendance and treatment engagement was better. They engaged in less sexual risk behavior. Their mood and their affect was improved. And there were some treatment response predictors there. 26 to 27 studies showed that this was, again, the meta-analysis there, longer retention. And look, retention is the name of the game, especially with fentanyl being placed in the, being included with the methamphetamine or with cocaine these days. People aren't retained in treatment, they're going to die. I mean, and what we know is people transitioning from either incarceration or on release, or individuals leaving a residential program are at a much greater risk for overdose and death. There were more therapy sessions attended, a greater utilization of other services, medical services and mental health services, which is huge. If we can get people engaged in those recovery-related behaviors other than just substance use treatment, it's going to benefit both the individual, it's going to benefit their family and their community. And then the increases in positive affect and decreases in negative affect. And what we know is that if people are feeling better, if we're increasing their self-esteem and self-efficacy, they're going to engage in those behaviors that are pro-social, type behaviors, and engage in the recovery support that we ultimately hope that they will. 5 systematic reviews that we talk about: best evidence of effectiveness, other approaches are less effective, including CBT and CRA. And then more recently, though, physical exercise has really come into the scene here as it relates to the treatment for stimulant use disorder. Dr. Nora Volkov is a huge proponent of exercise. Rick Rawson at UCLA, they were working in a residential program called Cry Help. They implemented exercise versus education and got some pretty dramatic effects on that. So moving on to CBT. You're all familiar with CBT. It's incredibly effective at both working with individuals who have mental health disorders, but also substance use disorders. Skill development and helping people gain sort of an understanding of their behavior as it relates to so how they feel and how they think. You're looking at that cognitive triad, and in gaining initial abstinence from in reducing drug or alcohol use, but also in terms of a return to drug use. It helps people develop skills. It helps them to develop a structure in their life to allow them to support recovery. That's the real value of CBT. The key concepts are encourage and reinforce behavior change, help to identify which behaviors we want to change, avoid those high risk settings. I mean, if you, if every time you get together with somebody down the street, you use a substance, well, the chances are the next time you get together with them, you're going to use. And so eventually you're going to have to make some changes to the individuals you associate with, the type of behaviors that you engage in, if you want to be able to sustain a recovery, identifying those high risk situations. At the same time, identifying low risk situations, things that really end up supporting your recovery, those people, places, situations that you can sort of do the right thing, engage in the right, the right type behavior. Initially, people have real challenges in identifying, those sort of low risk situations. And so it may be that what we have to do is to help them develop some of those things over a period of time. So develop positive coping skills and coping mechanisms, including thought stopping. Understand why they're reacting to something in their environment. Either having the physiological response when there's a certain smell, or when they see somebody using, and we know through the work done at E.D. London and Nora Volkoff in their brain imaging labs, that it's that craving is incredibly powerful. And if we don't sort of address ways and help patients address ways to reduce craving, or to be able to manage their craving when they are triggered, we're not doing them a service. So, and really looking to prevent the abstinence violation. Lots of times people say, well, I used a little bit, I might as well just keep using. And the reality is that we know that this is a chronic condition. There are going to be periods of time, periods of abstinence, followed by hopefully short periods of a return to use. And if we can keep those people engaged in care and not shame them, or not provide, no finger wagging that goes along with, when they come back in, which I'm sure you don't do, but it used to be that was the standard of care, was shaming individuals. And we know that doesn't work, because people won't return for treatment. The other thing about CBT, and I usually mention this when I talk about CBT. My dentist, if the substance use disorder treatment field did what my dentist did, we'd keep people in treatment longer, and our attendance at sessions would be much better. When my appointment is coming up, I get a text message from my dentist, I get a phone call, and I get an email. They want to make sure that I'm going to attend. And so, ideally, if we can be as diligent, in terms of following up with our patients, and not, make it such that, well, look, if you're serious about this, you're going to call us. Well, the reality is that their brain isn't functioning at the level that it will, or the level we want it to. So they're going to make bad decisions. I mean, that just goes without saying. Behavioral concepts as it relates to CBT strategies emphasize behavior change. There's that saying, get your mind out of the gutter, and usually the response is I would, but the rest of my body's in the gutter, so I can't get my mind out of the gutter. So the reality is that we look to change behavior. Once we change some behavior, we can actually change some thinking, and thinking strategies, and how people feel. Setting a schedule, scheduling really helps to promote engagement in those pro-social behaviors. If you don't know, as a clinician, if you don't know what your patient is doing throughout the course of their day, based upon a schedule that they have determined and shared with you, then you're probably not doing the best, doing right by them. Scheduling should be an aspect that takes place every single time you see a patient. Help them avoid high-risk situations, engage in those low-risk situations, and You do role playing where you can practice, coping skills, drug refusal skills, those sorts of identifying sort of situations that could be problematic. We have summer coming up, people are going to get out, we got holidays coming up. What are some of those challenges with individuals who are in recovery, with Memorial Day, with 4th of July, those sorts of things. Kathy Carroll was, she was at Yale University. Unfortunately, she passed away recently. She was really a huge advocate and proponent of CBT, developed the CBT for CBT, computer-based technology for CBT. I recommend you look it up. But way she defined functional analysis is it's a way for clinicians to be curious about their patient, finding out sort of when they use drugs, why is it that they like using drugs? What happens when they use substances? Where and with whom are they, are they purchasing or using with? What's some of those external cues in the environment, those environmental cues, or those emotional states, whether it's anger or depression or anxiety or sadness, any of those sorts of things that trigger craving. Helping them understand sort of, their use and how their behavior and their thoughts are impacted by their use is one of the best things that we can do with a patient. And using the 5 W's or a functional analysis can really help us understand that a little bit. Research for CBT, Kathy Carroll and Rounsaville, Frank Gavin as well. There's a huge amount of literature for CBT. Though, again, going back, as it relates to stimulant use disorder, not nearly as much literature that shows a significant effect for stimulant use disorder as contingency management does. Take a look at the website. We have it down here, CBT for CBT. That's Kathy Carroll's website. Let's talk a little bit about community reinforcement approach. So CRA, it's a combination of behavioral strategies that really looks to incorporate sort of aspects of the environment, those contingencies in the environment that can be brought to bear on an individual's lifestyle. So we can use their family, we can use the church or their pastor, or we can use the criminal justice system or their primary care provider. So, I mean, it's really sort of, we always talk about it, it takes a village to raise a kid. Well, the reality is it takes a community to support recovery. If we're going to have the best shot, we're going to have to be able to use those resources in the community to help support an individual's lifestyle. CRA, again, behavioral skills training. While we on many instances, we think that, some of these things are just, it's intuitive. People should know that you can't hang out with people use. Well, yeah, that may be the case. But again, we're not talking about individuals who are operating at their utmost in terms of their cognitive capacity. They are challenged when it comes to decision making. And what we know about, decision making is that the more often that we have to make a decision regarding something, the less likely we are to make the right decision. If when I wake up, I'm thinking, I'm not going to use today. I'm not going to use today. I'm not going to use today. If I am approached repeatedly, or if there are things in my environment that challenge that decision, eventually I'm going to give in. And for those of you who have children, no. Well, I'll tell you, when one of your children continually asks you about something, eventually there's that fatigue that sets in and you give in, right? And that intermittent reinforcement is incredibly powerful. So they're going to be relentless when it comes to that. Social and recreational counseling. hey, getting people engaged in behaviors that they used to enjoy, that they look forward to, getting their family involved in that through marital therapy as well. Motivational enhancement, either through, contingencies, can be important, but also using other motivations within the environment. Vocational rehab, job counseling, or education. Like, let's face it, if somebody doesn't have a job to go to, if they don't have education, or educational pursuits, it's pretty unlikely that they're going to be successful in their recovery. We just know that, because it's so difficult to fill up your day with pro-social behaviors if you're not engaging things that allow you to function independently, that will build self-esteem, and that makes you feel as though you're a valued member of the community. And then, of course, relapse prevention, or helping people to avoid a return to drug use. Some of the CRA topics, again, include functional analysis. So there's some overlap between CBT and that. Drug refusal skills, practicing. So you're not approached, so that you're not going into making a decision or a situation where you have to make a decision cold. Let's face it. I mean, anybody who, when you're first learning to run a group, boy, it feels pretty challenging, and you try not to let people see you sweat. And so that's why we do role plays, in counseling supervision as well, individual as well as group role plays, so that we're better prepared when situations come up in a group setting. Additionally, that might be why we start out as a co-facilitator and not necessarily as a facilitator. So those behaviors get modeled, and the principles of modeling. So we can model behaviors for our patients as well, so that they can have a better understanding of how they might be able to take those skills and apply them in a real life setting. So, that helping people to identify sort of aspects of the relationship that they want to see their partner engage in more of, and aspects of the relationship that they would like to see their partner engage less on. Really, what you're trying to do is enhance communication. And, when people use substances, we tend not to be the best communicators. And then again, remember to be nice. I mean, and it seems like it's a given, but it isn't always like that. People don't always get treated the way they want, and there's a lot of stigma around mental health. There's a lot of stigma around substance use. And then the National Institute on Drug Abuse has a CRA manual that includes vouchers specific for stimulant use, for cocaine use. MI, again, helps to initiate positive change and change their life, getting people to talk about change, helping people to engage in change talk, reducing sustained talk. In a randomized clinical trial, MI demonstrated positive benefit with decreased MA use, lower craving and participation, receiving MI regardless of the intensity. So look, let's face it, you work with a part of society nobody else wants to work with. You work with the most difficult patients, individuals who don't have a lot of resources, individuals who have experienced trauma, a significant amount of trauma in their life, have mental health challenges, have housing challenges, in addition to their substance use disorder. You work with the most difficult patients, and a lot of people don't want to work with them. A lot of people don't want to work with them. And so what we know about your using MI is it reduces burnout. There's been some literature that shows that MI reduces burnout. So you're turning over responsibility for making changes to individuals is ultimately going to help you. Okay, it's ultimately going to help you. Exercise. Exercise. So exercise as a treatment intervention. This is the Rawson study in terms of exercise for methamphetamine use that I mentioned earlier. This was done at CRI-Help, which is a residential program in Los Angeles. They had, individuals were randomized either to a health education group or to an exercise group. You can see the sample size was pretty evenly split. The exercise group got 3 days a week for 1 hour. The health education group got 3 days a week as well for 1 hour. There was a trainer. We did have an exercise physiologist on staff who helped us with to develop the exercise program. The summary is for individuals in the first 100 days of meth recovery. Okay, exercise improved physical conditioning, it reduced weight gain, improves cardiovascular functioning, including heart rate variability. So it allowed people to expand, go from resting to an increased heart rate, reduces symptoms of anxiety and depression. And that is huge, especially in the population that we treat. A lot of patients end up, self-managing, self-medicating their anxiety or their depression, and ultimately exacerbating it because the drug that they're using only helps for a short period of time. So getting individuals to engage in exercise is going to help with their mental health. It reduces craving for methamphetamine use. It enhances the dopamine recovery system. So what we've seen is that for individuals who engage in exercise, it improves their cognitive functioning. So if we can get them engaged in exercise, their decision-making power is going to be enhanced. And what better than to get people to, have an enhanced, decision-making when it comes to engaging or not engaging in those pro-social behaviors. And it reduces relapse to methamphetamine post-discharge, except in those very, very heavy users. So, it was done in a residential program. And of course, unfortunately, we didn't have, the resources for them to continue once they, an exercise routine once they left. But the reality is that hopefully we can get people to take that behavior that they learned within a residential setting and transfer it into an outpatient setting, along with those other recovery skills, recovery related skills. So trust, it's, Dr. Rawson was the primary developer of the matrix model, along with Gene Obert and Michael McMahan. I was involved in the evaluation of that and some of the revisions of the matrix model. Trust takes a number of, in fact, it takes all of those interventions that I mentioned outside of any medications, and we put them together to create an integrated, behavioral approach. Do we know if it works? No, we don't. We'll be straight up with you. We don't know it works, but because there have not been any clinical trials of it. But with people struggling to treat individuals with stimulant use disorder, our sense was, let's take all of those things that there is evidence for. Let's combine them and see if we can come up with an approach to utilize the best of the best of what we have. And that's what we came up with Trust. Again, multi-component program for the treatment of individuals with stimulant use disorders. The contents include motivational incentives based on, contingency management research, elements of CBT. We've taken a bunch of stuff from the matrix model. We've taken elements from the community reinforcement approach, motivational interviewing skills. So look, in Trust, our intention was not to train people on MI. That's not, it's not an extensive training on MI, but what we wanted to do was to provide people the reminder of the value of utilizing MI, the value of being able to, engage people in a discussion around change and get them to convince themselves that change is important. and certainly utilizing those MI skills of open-ended questions, affirmations, reflective listening, and those summaries will do that. Interesting, what we know about affirmations, if they're genuine, they increase change talk and they decrease sustained talk. So you're providing a genuine affirmation to your patients, the patients you're working with, is going to get them to engage in the behavior in the discussion that we want them to, regardless of whether we think that they're telling us what they want to hear, right? Or what they think we want to hear. The fact of the matter is that we all engage in the behavior, fake it till you make it, right? So let's do that. And sometimes as counselors, as clinicians, as trainers, we have to fake it until we make it. And it becomes natural for us. It becomes part of who we are. Physical exercise. We're going to talk a little bit about that. Self-help, moderation management, getting people to participate and expand the purview of their recovery outside of the milieu, the therapeutic milieu that we are involved in. The more people we can get involved in an individual's recovery, the better off they're ultimately going to be. And so, and in trust, we include, an appendix of other evidence-based practices, but also it's a resource. Trust it's not meant to replace anything that you already do. That's not our intention. Our intention wasn't to say this is the best and so this is what you should do. Our intention was to provide a resource. Our intention is to say, hey, maybe you can incorporate some of this into what you find that you're already doing. The priorities for trust is keeping people in treatment, being compassionate, respectful, non-judgmental, creating a safe, honest, trusting environment. If we can do that for our patients, they're going to continue to come back, regardless of what they do, whether they return to use or not. Getting them to come back is crucial. And our being, in many ways, relentless, calling them, getting on the phone. Hey, I know you left treatment. It wasn't working out for you, before. Have you thought about coming back? I just want you to know that we're here if you decide to come back. Let us know how we can help. Following up with our patients and getting them to sign a consent so that you can follow them up after they leave treatment is crucial. Again, people who are not in treatment die. I mean, that's just, it's a fact. They die. Individuals who have mental health and substance use disorders, they lose about a third of their life, 25 years. 25 years of lost life for the same conditions that the general population does, right? Cardiac conditions, diabetes, hypertension, the same exact thing. It's important for us to keep them in treatment and link them to those other services. Again, so providing evidence-based guidance, information, support, keeping people in treatment, involving their family members, other community members is going to be really helpful. Those are our priorities. The manual is a framework of how to use multiple evidence-based practices. It's a 12-week protocol with ongoing CM, motivational incentives. Again, I won't go into detail. It's really identifying specific target behavior and then supporting that target behavior with a contingency. So one of the things that we recommended is that a very simple incentive program, either giving a $5 gift card for orientation attendance, $5 gift card for attendance at a group or an individual, up to $75 over the course of the 12-week. And when a person reaches the $75 limit, that's it. And then what we've been asking programs to do is to provide a follow-up incentive so that we can get patients to complete an evaluation of the program, so that we can get information as to whether or not what they're finding effective, what they're finding useful, so that we can create a feedback loop $25 isn't too much. That's really not part of the incentive program, but rather that's to allow people to complete an evaluation. And in many ways, we've all done that. We've received, a survey and they say, oh, well, we'll send you an Amazon gift card if you complete, spend 20 minutes. And that's sort of what this is. Again, MI, it is part of, and we recognize the value of MI as being part of the evidence-based practice. We know that people entering treatment, they're embarrassed, they don't want to, they're feeling some shame and some guilt. And even at that, they may get defensive, about, and we want that. We want them to speak up for themselves. And so it's important for us to be able to engage them in their recovery. We talked about CBT again. We've included this as part of trust because we recognize the value of skill development. CBT and CRA include an integral component about skill development. Unless we can get people to recognize challenges their environment, including people, places, and situation, be able to avoid those, be able to cope with them, those emotional sort of challenges that we're facing, whether it's stress or anxiety or depression, or for that matter, success. Lots of times when I've seen, some of our patients, they get a job and they get their first paycheck and boom, they're triggered and they're off using. And so, there are very positive aspects of their life that can be triggering and help them to recognize, be able to anticipate what some of those things are. And so skill development and getting people to be able to interact in their environment in such a way where they can control more of their environment than they used to be able to is really going to be helpful. When I was, one of my first internships as a social worker was at a program called Bridge a Way Across. And I was assigned all the kids under the age, I think, of 12. And it was impossible to get them to talk about things that were going on in their life until, and I don't think you could do this today. And I mean, this was a very long time ago. I had 4 kids. I would load them up in my truck. I know it's bad. I hear you. I would take them to the park and we would exercise. I would go to McDonald's and feed them. And it was amazing how the combination of the exercise and providing them some nourishment. I know McDonald's isn't the best. I get it. But how that opened people up, those young people. I couldn't do that today, probably, because I would get thrown in jail and there's boundary issues. I totally get it. But the fact is that what you all talked about in terms of making it part of the treatment milieu, if you can do that, then we're going to be able to, our hope is be able to make that as a routine for them. We know that continuing care, it's a chronic condition. And nowadays, more than anything, a lapse to substance use really could mean a loss of life. And, as I mentioned, the CDC came out with the 12-month period ending August of 2020, 88,000 overdose deaths. 88,000. It's phenomenal, right? So, we need to keep people in treatment. Evidence-based practices can be added to trust. There's the list that's provided. Overarching priority is retention. And we know from, the founders of AA and decades of research show that the longer a person is involved in a recovery process, regardless of whether they're completely abstinent, as long as they remain in that process, right, the less likely they are to use, the less they use, the less likely they are going to be involved in criminal activities, and the better functioning they're, a member of society they're going to be. Promoting retention, what we know is non-judgmental attitude, positive incentives, transportation if you can, childcare is really good. Having snacks, I'll tell you, in the opioid treatment program that I ran, we had coffee. Maybe I should rephrase that. We had sugar and we had some coffee, because our patients love to use sugar with their coffee, and so, you know, for them, anytime they come in, man, the first place they went to was the coffee. So having snacks or drinks are, you know, available. Childcare, having flexible hours and not being so rigid with our hours, and then using, you know, care coordination between the providers. The components: orientation, using MI, using incentives. We have drug cessation groups. There's 4 drug cessation groups, weekly recovery skills group, individual coaching sessions, and then weekly continuing care group. Our training is 8 2-hour Zoom trainings. And then follow that, we have bi-monthly coaching for 3 months, and then monthly coaching where we do case studies. We talk about how it's going. What are some of the things that are working well? What are some of the things that, you know, are a little bit more challenging? You know, the data, we don't collect much data. Most of the data is collect on attendance, which you already collect, no doubt, attendance and the use of the contingency management. You know, again, the components are MI, using MI, the drug cessation groups. So there's the format. We use scheduling. Here's some of the handouts. We talk about, you know, drug using paraphernalia and friends, triggers, and thought stopping. Talk to people about their brain and stimulant recovery, and about how, you know, how their thought processes are going to, you know, improve. We have a recovery skills group within 90-minute sessions, you know, and it's built on evidence-based practices, CRA and the matrix model. We help people identify what really keeps their recovery sort of in place. It keeps it solid. I'm sure any of you in recovery can, if you were to look at some of those behaviors that help keep you in recovery and keep you stable, you'll be able to identify those 5, you know, a number of behaviors, and also identify those things that you're avoiding. And what we know is that those things change over time, because we know that recovery is fluid. Internal and external questionnaires, trigger questionnaires. So there, you know, we have handouts, we have the patient workbook for you, identifying high and low risk situations, individual sessions, you know, to really help establish that one-on-one connection. And, you know, sometimes people don't feel comfortable in a group situation until they get, you know, they get comfortable in there. They may feel better in terms of interacting with you individually. Our recommendation is that you have the same person that does the assessments, that does the orientation, does individual and group sessions, to maintain that continuity with folks. And exercise. That's my email address, and Dr. Rawson's email address at UVM, my email address at UCLA. And, you know, don't hesitate to reach out to us, ask us some questions, and we'll get those materials to you. Fuad?
We have the recorded session. We will have the recorded session on our platform. So at some point, if you need this information again, you can access it. Al, I can't thank you enough. This was an incredibly helpful, what an information-packed hour and a half.